Hello, my name is Marilyn Fake. I'm with mesocare.org. I would like to welcome everyone to our first of several series of lectures. Today our guest speaker is Vicki DeVito. She is a physician's assistant with the Department of Thoracic, Head and Neck Medical Oncology at MD Anderson Cancer Center in Houston, Texas. Vicki graduated from college in New York and graduated from Cornell University and received a Bachelor of Science degree as a physician's assistant. She's been a physician's assistant for 25 years, 5 years at Oncology Department at MD Anderson. Welcome, Vicki.
Thank you. Hello, everybody. Welcome. Today I'm going to talk about malignant pleural mesothelioma. Just going to talk about the outline that I'm going to talk about today. We're going to talk a little bit about the background of mesothelioma, which will include the epidemiology, which is causative factors, pathology, histology, staging. Then we're going to talk a little bit about resectable types of mesothelioma. We're going to talk a little bit about surgery aspects because Sharon Myers will be speaking on that at a later date. We're going to not talk about radiation too much because we're going to have another talk about that at a later date, and I'm going to talk about chemotherapy in resectable mesothelioma, and then I'm going to talk about chemotherapy in unresectable mesothelioma. The worldwide incidence of mesothelioma hasn't changed too much over the years. In the USA, there's going to be 3,000 new cases per year diagnosed. Western Europe, more than 5,000 cases. China, 4,000. Japan, 1,000. Australia, 600 new cases a year. The link between asbestos and malignant mesothelioma was first noted in South Africa in 1870. 72,000 more cases are expected in the United States in the next 20 years. Worldwide, the incidence is expected to peak in about 2020. The reason why we're going to keep seeing mesothelioma, one of the reasons anyway, is an estimated 10 million New Yorkers were exposed on 9/11 due to airborne asbestos. The World Trade Center was constructed between 1966 and 1977, and that was prior to the current OSHA guidelines limiting use of asbestos in public buildings. The epidemiology or risk factors for mesothelioma, males to females, the ratio is 3:1. The latency period is 20 to 50 years from the time of environmental exposure, and most people are in the 6th to 8th decade of life. Now, the risk factors are changing, however, because the first responders of 9/11 are already being diagnosed with asbestos-related lung disease, such as asbestosis, asthma, and COPD. The top 10 causative agents for mesothelioma: asbestos, 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 but simian virus, number 40, which was used in live polio vaccines. In the 1940s, there was a couple of cases of mesothelioma that were attributed to the simian virus. It was actually a monkey kidney cell that the polio live virus was grown on, and unfortunately, this was just discontinued in 1963 in the United States, this type of polio vaccine, and in Europe, they used it till 1978. The development of mesothelioma from the asbestos fibers is not related to a chemical component to the asbestos. It's actually the fibers themselves. There's a short fiber and a long fiber in asbestos. The long, thin fibers are the stimulus for the mesothelioma. The short, broad fibers are usually coughed out when a patient is exposed. The cilia in our respiratory tract will cough out the short fibers. The longer fibers, unfortunately, settle to the bottom of the lung, the pleura, and that's how it all starts. And if you swallow the asbestos fibers, the long fibers can get into your GI tract, and that is a causative agent of peritoneal or abdominal mesothelioma. The histopathology for mesothelioma sometimes is confused with a lung cancer type called adenocarcinoma, and the best way to distinguish is to use an electron microscope to distinguish between the two. There's a few immunohistochemical markers for mesothelioma. The biggest one that you want to watch out for is the last one on the list, TTF1 negative. Adenocarcinoma is always TTF1 positive. The histologic subtype, these are photos of actually looking at mesothelioma under the microscope. The top slide is epithelioid type, and that's the most common. That's 60 to 75% of all pleural mesothelioma types. Biphasic is 15 to 20%, and sarcomatoid is 10 to 15%. The biggest difference between these subtypes, epithelioid seems to be a slower growing, and sarcomatoid is a faster growing, and the biphasic is a combination between the two. Screening markers. In certain cancers, there are screening markers that you can find in blood tests. There are actually proteins in the blood that serve as markers. Unfortunately, in lung cancers, there are no markers. And in mesothelioma, we do have 2 screening markers. They're not 100%, but at least it's a start. There's also a few other potential markers being studied right now. The 2 that we have are the osteopontin and SMRP. And the SMRP is being used most commonly right now. It is not a good marker for sarcomatoid type of mesothelioma. The staging system for mesothelioma, there's actually 3 types. I have 2 here. The next slide will show the third. The top one, the Bouchard one, is not really used much anymore. The IMIG is the most popular one being used, and that uses what's called a TNM staging. And T stands for tumor, and the numbers after the tumor delineates the extent of tumor. The N stands for lymph nodes, the nodes themselves indicating involvement or lack of involvement of the lymph nodes. The M delineates the presence or absence of metastases. In the UK, the Brigham system is most commonly used, and this one pretty much just says, is it limited, is it extensive? And a lot of cancer centers actually use a combination of the IMIG, which was the last slide, the IMIG and the Brigham.